Well, good afternoon or good evening. It's nice to be with all of you here on a Monday evening after you've been practicing all day. If I were in town, I would be too. I'm a general internist by training. I've been in practice since 1993. I always start with a story about a patient because it's about the patients after all. And so this is about some patients and something I learned in practice years ago. And that is, there's something different between women patients and men patients that you can tell before you ever go in the room, before you ever see a new patient. And that is, with men, you have no idea how old they are. If it's a Bill or a Bob or a John, he could be 18 or 85, right? But women's names go in and out of fashion. So my name is Grace. I'm 51. When I was in school, everybody was named Kathy and Donna and Lisa and Sharon. And my name was Grace, which I thought was weird. I didn't like it very much. I didn't know that my mother was an innovator and that right after Grace came Faith, Hope, Charity, and it all went away with Chastity and Sonny and Cher. And then after that, the hippies started having their kids, and it was Autumns and Ferns, Willows. And I didn't realize that my generation did that with our kids too. I have two daughters, Katie and Robin. They're young adults now, but when Katie came home from first grade in North Carolina, she said, "Mommy, there's a difference between black girls and white girls." I said, "Uh-oh." And she said, "All the white girls' name ends with an E sound, like Katie and Callie and Christy. And all the black girls' names ends with an A sound, like Yvonda and Shalonda." And she said, "And that's the only difference." I said, "Progress has been made." What happened then is my daughter Robin went in school, and I realized very quickly that I'd done something in fashion with her too. And that is that Robin was one of those names you couldn't really tell the gender. And that was the years of the Taylors and the Jordans, and we're all hiring them now. And so I don't know what the next ones are going to do, but what I do know is those that are a little older than us did the same thing. And so for those of you that have been in practice as long as I do, you know that the Aprils and the Mays and the Junes are a little older than me. They're in their 60s. We went through the spring months. And then there were the jewels. There was Jewel and Opal and Ruby and Pearl, right? They're in their 70s. Well, it's the flowers that are dying right now. I have three patients I want to tell you about very briefly, and then I'll give you my talk. One is Hyacinth, and one is Iris, and one is Rose. I think Rose has a sister named Violet, but I'm not going to talk about her. So Iris is somebody that I've been taking care of since I went into practice in 1993, and she's 89 years old now. And she's one of those little ladies that we all hope that will be that way one day. Her husband passed away a few years ago, but she lives alone. She's got a wonderful brain. She still drives. She's independent. She's fit. I have her on one pill, which is a low-dose ACE inhibitor. I tell her just to lick it every year because I'm afraid I'm going to kill her if I give her more than that. She does real well. And I see her a year later, up until this past year, where I did that as usual in October, and then she got the norovirus, which came through like it did in a lot of the country right after Christmas. And she didn't call my office, which was actually open 7 days a week now. She called the beauty parlor, which is what those folks do, as you well know. And she asked the ladies at the beauty parlor what to do, and they told her to go to the emergency room, so she did. And while she was in the emergency room, she got too much fluid and was put into pulmonary edema, and then she got admitted. And they put a Foley catheter in her bladder, and they gave her too many drugs, and then she had a stroke, and then they ruled her out for MI, and then she ended up in a nursing home. And when I saw her back right after January, it was like a different lady. She came in a wheelchair, on oxygen, on 20 drugs, falling all over the place with a black eye from her fall at the nursing home. And two sons, one of who's a nurse. They're pretty sophisticated, educated people that had no idea what to do with her. My second lady is Hyacinth, and I was taking care of her for years with her type 1 diabetes. She's in her 80s too, but she's a little bit paranoid. And a few years ago, she became what we call in the South on our church rolls a shut-in. Did y'all ever have the shut-ins on your church rolls out here? I don't know about it, but anyway, she wouldn't come to see me in the office anymore, and as a result of that, after about 2 or 3 years, I couldn't see her anymore because there was no compelling reason to go out to her home, and I couldn't keep prescribing her insulin, and I couldn't get her in the office. But she actually goes to my church, and I see her name on the shut-in list ever so often, and I worry about her. Well, Iris, my first patient, how much money do you think that we probably made off her? We all made money off of her. You know, Cornerstone Healthcare did, the hospital did, the hospitalist did, the nursing home did, certainly the pharmaceutical company did. I think the local hospital told me it was probably about a $200,000 bill when it was all said and done. The next lady, Hyacinth, did not have any bills to speak of, but one of these days, because she's not getting good care, she's probably going to end up in that emergency room door too, and probably in much worse shape than what she otherwise would be, and we're going to have a big bill as a result of that too. My third lady, Rose, actually came to my practice on a Sunday when we were open, and she also had the norovirus, and we gave her some fluids that day. I saw her back the next day, she also had 2 sons. This is actually true, around the same time, and she did well. And we made about $500, I think, is what we charged off of that. Now, within the context of who got the best care, I actually think it was the third lady. But our healthcare system is not set up for the third lady right now, and so when we really are talking about what we're talking about tonight, remember it's about the patient. And remember that when we're talking about value and what we need to do, it's about folks like Iris and Rose and Hyacinth that are real people that you and I see every day. So whenever anybody talks about doctors, as you heard it earlier today, we're always said that we can't get anything done right because we're a bunch of cats, right? Getting doctors to do anything is like herding cats. Well, we're not cats. And so I'm going to tell you about the journey of my organization, Cornerstone Healthcare. We formed in 1995, around the time you all were forming your IPA here. We were a group of 5 or 6 docs that got around a table in High Point, North Carolina, because we were sure something was happening in healthcare. There was the Clinton era, and there was going to be reform, there were going to be HMOs, there was going to be risk and all that, and we needed to do something. So we actually talked all of our partners in 16 practices into forming a multi-specialty practice in High Point in 1995, and we stayed together, and now we're about 370 strong throughout the Piedmont Triad area of North Carolina. We are just as passionate about our independence as any of you all are. We're on staff at 15 hospitals that are part of 8 health systems. And we're not about feeding the beast. We're about doing what's right with patients. But we've struggled, like you all have, with the changes, and this is more than anything else just a story of our journey. It's a journey we're going to take together, and I want to remind you that people think that where we need to go with healthcare is a place that we can't get to as doctors. So in 1970, Fortune magazine said the time has come for radical change. The management of medical care, after all, has become too important to leave to doctors, who, after all, are not managers to begin with. So this is another time of radical change. And perhaps what happened in 1970 is when everybody decided that it wasn't, that it was too important for doctors, is where part of the problem began. I think that we need to understand very quickly that we're not cats, and that we can do this. So let's talk about what's going on out there. I'll tell you the story of what my organization's doing right now, and then let's get on with it because we got a lot of work to do. So we all know that the healthcare system has some huge problems. In the old days, we all talked about it was the best healthcare system in the world. Our presidents always said that in their State of the Union addresses. The last one that said that was in the year 2000, and it hasn't been said since then for all the reasons that we're aware of with the cost and the quality. We've seen the data. We know how expensive it is. We know how most of the gross domestic product of our country continues to be eaten up by health care. I'm not going to go into that. We've seen those things. What you do need to hear, though, is that the value of the fee-for-service system that we've all been in is destroyed for everybody. So those of us that are physicians are on a treadmill all day long, seeing more and more patients as fees get cut. The patients are getting the type of care that Iris got and not the type of care that Rose got, and so that's not a particularly good thing for them, except when they absolutely have to be there. The employers are spending so much on health care that they're not spending anything else anymore on any other type of investment, which is one of the reasons that most of our industries has gone to China. And certainly our society has other things that it might be able to invest in, such as education and infrastructure, if we were not having a value destruction from the fee-for-service. But by the time that health care is the major story in our Foreign Affairs Journal, which it was in October of 2011, I think is when this came out, you know we're in trouble. Because when the Foreign Affairs Journal says, how are we going to compete as a nation going forward, and Peter Orszag says it has to be doing something about health care, it's not just about us anymore, it's about what we've got to do. So what my organization started talking about is the default future. Any of you ever heard of your default future? That's the future you have if you just keep doing what you're doing and letting the future happen to you. It's the one we all have if we passively let things just happen to us and go along with the things that are going. It's inevitably what happens when somebody else is in charge of your future and you don't sort of take an existentialist approach to what you can do about that. You don't have to have your default future, and we as a nation don't have to have it, and we as physicians don't need to have it. But to do it, you're going to have to rewrite your future. You're going to have alternative language about what that's going to be. You're going to have to create a vision for that future, and then you're going to have a good strategy to get there. Now, a vision without a strategy is called a hallucination. Have any of you ever been to any of these retreats with hospitals or thus and such where you all sit around and you vision together? That's what most of us do when we're getting together trying to do things, but that's not what a strategy is. It's not a goal, it's not a hope, it's not an aspiration. It's actually a lot like practice in medicine. If you think about what a strategy does, it solves real problems. You have to make an accurate diagnosis. You have to have a path to get there. You have to weigh the risk versus the benefits of the decision you've made. And then you're going to have to basically come up with a way of doing that that makes sense when you've looked at all the other alternatives. If you think about it, that's not too different than what an internist does or what a surgeon does, in that you're going to have an approach to things that's diagnostic and tactical and based on evidence, and then you're going to have to go about understanding why you've chosen that rather than another strategy. And I really think that physicians are probably well trained for what we've got ahead of us to do. It's just not the way that we usually think about it. So you also have to have leadership. And one of the things that I think that physicians have got to step up the plate to do is be the leaders to get us where we need to go. I don't believe it's going to happen without us. I do believe we have the capacity to do that. So the burning platform that we have out there is real. And if any of you think this is the 1990s or any of it's going to just go away, the difference this time around is the country is broke and we're all old. And that leaves for a very, very different type of world than what we thought it might have been in the past. So the value proposition is that if healthcare cost and utilization is unsustainable, and waste and variation is 30% of the problem out there, and lowering payments is not a good answer, because what that means is that people just do more and more, which is what's been the case in healthcare. Then if we can incentivize patients and providers and payers around value and appropriate utilization, then we might have a solution that's sustainable. The unsustainability of our system is based on the premise that it's going to continue to go up at an exponential rate. But the truth is, all we have to do, believe it or not, is go back down to a GDP of about 14%, which is what it was less than a decade ago, and then just trend with inflation after that. That's only about 10 to 20% of the waste. It's not 30% of the waste, which is what many folks think that's actually in the system that we could get out. The problem we've got is that these if you believe the value-based models are the solution to the future, we're all going to have to do a lot of things differently than what we've done before. And nobody is particularly in an ideal situation to get there. So if you're a big hospital, you've got a lot of capital, but you've got a lot of stuff. You've got a lot of bricks and mortars, and it's been about feeding the beast for the past 30 years. If you're a physician group, you don't have a lot of capital, because our business model more or less is to basically work as hard as you can, as efficiently as possible, and take home the rest as your paycheck. And so we don't tend to have a lot of capital as a result. And some people think maybe the insurers are going to be the ones to organize all this, because they understand some of the utilization and all that. But they don't particularly have the type of situation where they understand the real practice of medicine and what needs to be done. One way or the other, though, we're going to have to figure this out. We're going to have to innovate, or we're all going to get a really big, ugly haircut. Because the only solution out there, if we don't do something differently, is for somebody to cut our fees. And that's probably not sustainable, too. So a lot of times innovation happens around you and you don't realize it. So when I was a little girl, I grew up on a farm near a town called Siler City. You've heard that before. That was the town that was always mentioned on Mayberry. It was a real place where I grew up. And in Siler City, North Carolina, there used to be a fellow named Kenny. And Kenny Clark had a service station when I was a little girl. And he would put, he would come by. My mother never had to touch the gas tank. I don't know about your mother, but he would check the oil, he would do the windshield, and then he would fill her tank up with gas. But by the time I was a teenager, that was out of business. And instead we had something called the Exxon station, which was not too different than large integrated delivery systems. They owned everything from the oil rigs to the tank, right? That's no longer the model that we have for where I go to get gasoline now. I go to a place called Sheetz. You all have something like Sheetz out here, I'm sure. Sheetz came out of Altoona, Pennsylvania. And it's the most amazing place in the world. You can do anything there except get married, as far as I can tell. It's got a great bathroom, and if you're on the highway, the gas prices are always the best, and the food is delicious and wonderful, and anything you forgot in the car with the screaming kids is there. And it's wonderful. Well, if you think about that, that's actually 3 different business models, and the first one was maybe similar to a sole proprietor. And the second one was something maybe similar to a large integrated health delivery system. And the third might be where I think actually the future will be. When you hear the term population health management hub, think about a hub or a place where everything that's you need for your health care is there. It's not necessarily a big hospital. It's what things you need for your care. Where we will be going in healthcare, I believe, is not going to be about big hospital-centric systems or even big physician-centric systems. It's going to be centered around the patient and the patient's need. So the business model that we've been in a fee-for-volume world, our reimbursement has been for doing stuff. And it's been fee-for-service. The hospitals have the DRGs. We organize around departments or practices. And what you do is you get as efficient as you can at the departmental level. And the value drivers are volume. You do as much as what you do with whatever it is you do, as efficiently as possible at that level. And then your profits are the result of the volume. So it's in visits, it's in procedures, and it's in outpatient ancillary for those of us on the physician side of the world. And you invest in capacity. You invest in revenue-producing assets and patient referrals. Well, the value-based world we're going to, if we're able to get there, is different. The reimbursement's going to be differential. It's going to be how well you are able to do something at what cost. And the organizational model is going to be around conditions, populations, and focused factories. For those of you who are specialists, a focused factory means you are the absolute best place to get orthopedic care out there. You are a machine, and you may get paid something differently than the guy down the street. It's not going to be about everybody getting the same price anymore. It's about who can do that efficiently. The profit pools are in chronic condition management, population management, and wellness and prevention. So those of us that are dinosaurs called internists, who've been taking care of Medicare patients, that's actually going to be a very, very important place, because where chronic conditions are is where the new profit's going to be, because that's where most of the waste is now, because we do such a poor job of it. And the investments are going to be in information and in clinical integration, not in integration as in ownership, and in commercialization. There's going to be a lot of people out there who are going to scale this. So you all have a lot of understanding of risk out here in the West. We don't do that in North Carolina. There is zero risk capitated contracts in our state. But in a lot of the world, what we're having to basically think about is where the different types of payments are and how you're going to position yourself for that. You need to be thinking about the drivers of cost, because this is where there's the most opportunity, including chronic disease, the aging population, and hospital readmissions. If you have a heart failure patient and he or she is admitted to the hospital about 4 to 6 times a year, that's a $100,000 to $200,000 differential for those that you're able to keep out of the hospital on that one particular basis. So anyway, my organization, Cornerstone Healthcare, really started paying attention to one of my favorite theologians, Jerry Garcia, and decided that somebody somewhere had to do something. It was just incredibly pathetic that it had to be us. So in High Point, North Carolina, we started thinking a few years ago about our future. We were killing it in the fee-for-service world and have done really well, but we did not want to be the biggest trophy on some hospital system's shelf as our state became increasingly more consolidated. So what we did is we looked at what our options were. Who we are compared to when we started in '95 is that we are all over the place. This is now up to about 110 locations, affiliated with different hospitals, which is one reason we weren't so thrilled with the idea of being on one particular hospital affiliate. We have a lot of primary care practices. They've all been patient-centered medical home recognized, and a lot of specialists. We're about 55 to 60% specialty, depending on how you count our 100 mid-level providers. And we've been on one EMR for a long period of time, but we're 2 hours apart from one end of our geographic area than the other. And we basically are not too different than an IPA, but we're probably different enough within the context of a multi-specialty group that part of what I'm talking about will sound like a parallel universe to you, and part of it may sound somewhat familiar. The thing in 1995 when we got together, we were told by our attorneys to do what we needed to do, and we couldn't do it in the PHO model or an IPA model, that it would be, that we had to legally organize into a multi-specialty group. That's actually no longer the case because of some changes in the law and because of the things that we have now when it comes to information integration that can happen through health information exchange and data warehouses. There's a lot of things in this day and time that can be done in an IPA if you put the right type of infrastructure into it that could be very similar to some of the things that we were able to put together as a result of being a multi-specialty group. So basically, our docs decided that we had a strategic imperative. We felt like that we would be out of business as good as we were doing because our incomes were starting to decline. The cardiologists got whacked in 2008, as everybody knows, when the nuclear stress test went bad. The urologists were starting to get killed. Our primary care doctors were starting to be under some stresses. And we basically decided that a physician-led company that was able to figure out how to manage risk without being overly burdened with high fixed costs might be able to thrive in the new world that we were going to. And so we basically said, what do we want to do? Well, we wanted to make sure that all that we'd built over the last 17 years, that we continue to have a long-term return on investment out of that. And we don't mean selling it, we mean a return for all we've built up. We wanted to have an environment that was really about the enjoyable practice of medicine again, as opposed to just being on the treadmill. We wanted to provide financial stability for our physicians in a world that was really changing as much as is possible. And we wanted to reward our shareholders for the investments that we'd made in our practice over time. So we had some strategic choices to make. And every business has these same strategic choices. So at any particular time, you may be at the top of your business cycle or the bottom of your business cycle. But when there's a lot of change going on, at any time that you're thinking about your individual business, think about where you might want to be. Status quo is just doing what you're doing. And if you're killing it and tunning it, and the future's not getting ready to change, then maybe you want to do your default future because it may be the best one out there. It's no longer that in our neck of the woods for us. You might want to sell, and we actually looked at what we would be worth if we sold. We didn't want that future. We really value our independence. You can collaborate, and we've been doing a lot of that. We've been doing it with hospitals and all sorts of organizations, including some insurance companies. You can innovate. And I think innovate is where most people stop, and that's sort of the buzzword that's out there today. Innovation is about getting better in the system that you're at, that you're in. And if you're in a blue state, you talk about design. And if you're in a red state, you talk about high reliability. I actually think that if you actually got out of the political rhetoric that our politics have, where most of the language is about conservatism or liberalism, and you got into the language of the difference between high reliability, which is the conservative approach, versus design, which is the liberal approach, we could probably get a lot more done in Washington as well. But I don't actually think that innovation is where is the only place to go. The other thing is transformation. And transformation is different than innovation. Innovation is getting really good at the space you're in. But transformation is about something very, very different. So if you think about what transformation is, think about the music industry. Transformation, if you think about RCA Records, they probably thought when we were growing up that Columbia Records was their competitor. They had no idea there was going to be something called an iPod. And Xerox had never thought about there being something paperless like a computer. And certainly Kodak Film thought that Fujifilm was its competitor rather than a camera that was digital and needed no film at all. So transformation is about something that's so radically different that you don't even realize it's coming. And as much money as there is in healthcare, with as many opportunities as there are for other folks to make profit if we don't get our act together, there will be some transformation. So we might as well let it be us. So our organization decided that we needed to do something, and we decided we were going to transform. We were going to stop being a very good, well-respected multi-specialty medical group and look at what we could do instead. So we basically took a 5-pronged approach. We felt like that there were 5 things that had to be done. One was medical home, and I don't mean just the NCQA recognition program, which is step 1. I'm talking about really, really transforming the way we do primary care. The second is clinical integration, which is how we work together with everybody, specialists, primary care, skilled nursing facilities, hospitals across the spectrum. The third is information integration. We had to get really, really good at the types of things that we needed to share with one another. And we had to do this while we were completely reorganizing the way we were governed and structured. And we had to change all our contracts at the same time because in the world we're in, if we continue to do our fee-for-service contracts while doing all this, it's called bankruptcy. And so we felt like we had to do all of it at one time, and we've done that journey very, very quickly. So within the context of the medical home, that was a building that we built and started designing a couple of 100,000 square foot facilities in 2007 and went into the real estate business. My practice, as well as many others, is in this. It's open 7 days a week. It has diagnostic imaging, lab, infusion, primary care open 7 days a week, some of our specialists. And it's doing very, very well within the context of keeping people out of the hospital. We did several other things. We created a clinical pharmacy service that started by doing Coumadin management. We did some extended and weekend hours throughout the organization, and now I was just monitoring, it's gone from 22,000 visits to 28,000 over the last 2 years in terms of folks that we've seen in non-traditional hours. We trained all of our employees on what the concept of medical home was, started this infusion center so that patients like Iris could actually get IV fluids in our outpatient facility as opposed to the emergency room when it was appropriate. And we created something called Patient Care Advocates, where we used an analytic tool, and we were able to essentially call up our patients that we were able to identify that were diabetic with an A1C, an LDL, or a blood pressure out of control, who hadn't seen a primary care doctor in the last 6 months. And we used just some medical assistants making $13 an hour and invited them to come back and see their primary care doctor. And the results from that, which makes sense even in the fee-for-service world, were that the program paid for itself in about 3 months, and the results were far better than what we were getting from the patients that were going to the endocrinologist. Clinical integration is something that we're all going to have to understand. Hospitals are not the enemy, but they're not the whole solution either. The opportunities for saving money in the healthcare system are both in the hospital and with primary care. And for our specialists in particular, a lot of the things that needs to be done is specialists need to be leading within the hospital context, because so many of the things that could improve the care of patients in those settings needs to be managed by specialists. All of us together are going to have to be working on this. One of the things that Cornerstone looked at was where is the largest impact and savings to begin with. Some of the most important specialties to really begin thinking about clinical integration and improvement are primary care, cardiology, oncology, and orthopedics. We looked at those first when we started looking at our transformation. Information integration is a whole lot more than just your electronic medical record with its clinical decision support. We're on all scripts, they all terrible, okay? And we're as unhappy with ours or as happy with ours as anybody else is with theirs. But that's because they were actually not made for where we need to go with value-based care. They were not made for population health. We've had 3 stages of information in healthcare. The first had to do with the way we were paid. It's a 30-year-old mature technology. It's called practice management systems. It was about billing and collections and scheduling, because that's what it was. We're only about 25% through the clinical piece of it, which is electronic medical records and clinical decision support. But the piece that has to do with population health management is in its infancy, and nobody's doing it well, and you have to piece together various things and create it together. And at the end of the talk, I'll show you a little bit about what we're doing to do that. So in the last year, we put together a bunch of stuff really quickly. Our shareholders voted in to basically transform as quickly as possible into a population health management hub and value-based medicine. So we went live on an analytic tool in 2010. And then we started that patient care advocate program. And then we started meeting as service lines together. So for the first time, all our internists were meeting and our family physicians were meeting together. And our OBGYN practices were meeting together. And our cardiologists were meeting with our vascular surgeons. And our podiatrists and orthopods and rheumatologists were meeting together. And they were coming up with ways that they thought that they could do things more efficiently, and then reporting back to one another. And then we put together several very intense programs that we thought would make a great deal of difference. that I'm going to show you as soon as I get this little button to work. What? Yeah, maybe What we basically did is we looked for where there might be opportunity. We all know when there's opportunity out there. The opportunity is what we see every day in our practice that we know is where the waste is. We developed care models around where we thought the waste was, and then we tried to quantify the impact so that we could improve it over time. And in that, I'm learning how to go backwards anyway. In that, we also stopped seeing every patient in front of us as being the same patient. So within the context of population health management, you have to realize that the healthy young person is different than somebody with at-risk problems, who's different with somebody with early chronic disease, who's different from somebody with late chronic disease, who's different from somebody that's at the end of their life. And if you can create ways of integrating the care for all these different types of individuals and groups, they don't all need the same thing. They don't all need a 99213 and a 15-minute office visit or a procedure. You can start designing care around the population. So we did several things. We basically started with a personalized cardiac care program where we took 2 or 3 of our cardiologists and embedded in a heart function clinic psychologists, social workers, pharmacists, and mid-level providers. And what we were able to do is identify on our analytics tool our 300 sickest class 4 heart failure patients and started seeing them on a regular basis in the clinic. So one guy had been in the hospital the first half of 2012 15 times. And since he's been in this program, he hasn't been once. Now, this was a gentleman that was 400 pounds with all the other chronic conditions that would go with that. And it makes a great deal of difference. We did something very similar with our cancer program. But one thing that we did in cancer program, after you get the chemo under evidence-based medicine protocols, most of the cost of oncology care is from non-oncology emergencies, because these folks have a lot of other chronic diseases and they get dropped through the cracks. So we actually embedded an internist in our cancer program, which apparently is making a great deal of difference. It's early on in its process. We have changed the way we're doing primary care. So some of our doctors now are seeing just the sickest chronic patients, and we have a team of folks working with a doctor, social worker, behavioral therapist. My partner, Richard Orr, used to see 35, 40 patients a day. He was one of our most productive docs. He had a nursing home, 2 nursing homes. And he's seeing about 10 patients a day now, and he's seeing them up to an hour at a time, if need be. And he's basically said, this is the way I've wanted to practice my whole life. He's not lazy. He's probably, in the gain share world that we're in right now, doing better and making more profit, if you will, for our organization than those that were just seeing patients or like he used to before, because those patients are staying out of the hospital and they're staying healthier. We also had just developed a special clinic for our Medicare and our Medicaid dual eligibles. They're about 40% of the spend, this group alone in America, in terms of health care costs, because they're poor, undereducated, and chronically ill. And by spending more time on this population, which we're all going to get to know better, I believe, with the Affordable Care Act and the expansion, it's going to make a great deal of difference. The final thing that we've started is our life care clinic. So our top 1% of patients, in terms of their overall comorbidities, we now have a new specialty called extensivists. Have y'all got extensivists out here yet? Okay. Always pay attention to the new word, because it means that they're paying you different. I used to be called an internist, and then it was changed to primary care physician, which had to do with a copay. And the specialists in the audience, how many of you are specialists? Okay, they just changed your name too. Have you heard yourself called a proceduralist yet? That means you're getting ready to get whacked. Hospitalist was about DRGs. That was a payment system too. And extensivist is a term that's being used now for those, I think they used to be called internists, but actually they're the folks that are following patients that are the sickest from the hospital to the skilled facility to home and do it in a coordinated manner. So we're working on a lot of things. Don't say that we've got all the answer. We've got one of our practices, the polychronic practice that's working with Rite Aid in a beta site where they've redesigned 6 of their Rite Aid pharmacies. And they have health coaches there to basically help some of our patients with issues like weight loss and how to use their asthma inhaler and all these types of things. They're doing it for free. Why is Rite Aid doing this for free? Because they just realized that they don't know where they're going to be in the future either, and they don't want to be a glorified convenience store. So they're trying to figure out their value, and we're trying to measure that for them. So the other practices that are not in these intense models I mentioned are getting together and trying to come up with their own top 3 things that will make a difference. We're starting to have some results. We've had about $7.4 million in monies in the last 3 years for meaningful use pay for performance and some of our early results on our early contracts. We have moved 100% of our contracts into value-based contracts. In North Carolina, that means something different than it does here. That has to do with gain share models. We're getting ready to move to risk, but in North Carolina, we have to fight the payers for it. They don't want risk because they're making a lot of money in the fee-for-service world too. We've had 2 co-management agreements. We've been able to negotiate with a hospital, one in oncology and one in cardiology, where we're paid to manage both the inpatient and outpatient service line and are paid for meeting both quality and cost parameters. And we believe that we're ready to go for some bundled payments, and we're going to invite select hospital partners to do that with us. So this was something that we were pretty proud of. What we know is that if you look at all the other Medicare ACOs in the country in this shared savings program, that the average ACO is about $10,000 a year, and that our cost actually is lower than this. Since we did this line, is about $7,800 a year, and it's going down every year. And it's been doing that as a result of some of these early things that we've put in place. What you'll notice is we're doing it with more mid-levels, with more primary care services, and specialty care is about average. So it's not like the docs are seeing the patients less often. What you'll see, though, is it's coming out of the hospital's hide, and it's coming out of imaging. Our imaging, which we own, is a little bit less than average, but our ED visits and hospital stays are a lot less than average. If we're able to sustain this, that's about $20 million in the end of the next 3 years in terms of what we should be able to get back off of that if we're able to sustain it. The cost is doing better than some of the others. So that's what we've done so far. That's not where we're stopping. We believe that there's a lot of things that are going to have to be put in place for us all to be successful as physician organizations. It requires scale. You all have scale in this area with the size of this IPA. It requires changing the way that you're getting paid, getting the patients involved. Usually at the end of the talk, somebody says, well, doctor, what about the patients? What stake do they have in this? Well, they do. We're going to have to figure out how to do that. It involves going to risk as soon as possible in strategic partnerships with hospitals and others. And it also involves a lot of money in technology and infrastructure advancements. And our organization is putting about $25 million into it, which is a lot for an organization our size. So we believe that there's a lot of competencies that are going to be required that it hasn't been out there in the world that we've been in a primary care practice, in a multi-specialty group practice. The care coordination and the clinical performance management, effectiveness analysis, all these types of things are really different than what we were all trained to do in med school. The American Medical Group Association, which you all are a member of and we are too, which is where Marielle and I have so much fun together, basically thinks there's about 9 things that are part of the infrastructure that's necessary, including quality and information and all these things that we mentioned before. It's really important to have the numbers. What our organization decided to do was that even if we're successful and nobody else is, we're still all going down because we don't think we're big enough. So we actually have taken the infrastructure that we've built and we've spun it off into an MSO called Cornerstone Health Enablement Strategic Solutions, or CHESS. And the idea being that in our area or region, there's going to be other groups out there. Some of them may be IPAs, some of them may be multi-specialty groups, some of them might even be small hospitals with employed physicians who are going to want to go down this journey too, but they're not going to be as far along as we are. So we think that we're going to be able to provide them probably 4 things. One is the analytic tools that we've invested in. The second is actually changing the way you provide care, the care model. Anybody that doesn't talk about changing the care model is just selling you stuff. It's actually about what the docs have to do, what we have to do as providers. It's about the contracting, and we think that we're not very good at it yet, and neither is anybody else. And so whatever we learn, we want to make sure that we're all learning and improving together. So what we believe is that there's 3 things to focus on: the waste, the reducing the variation in the way we do things, and increasing influence. How in the world are we going to get patients to do what we want them to do and get better unless we're doing things like the patient care advocate, Rite Aid, whatever it is? We don't know it yet. We're all going to have to figure that out together. And also influencing physicians. So we have bought a bunch of tools. Some of them have been national products. Some of them we've built ourselves. That's allowing us to look at all sorts of things differently. So we can pull down patients and get some information about where the costs are for the first time. For the first time this past year, we gave to all of our primary care doctors the top 30 patients that were predicted to cost them the most next year, because we have predictive modeling, and that was very powerful. Most of mine were right. They were right on. I could have probably told you who they were. There was one lady I couldn't figure out, and then I remembered her son was a doctor. And I think she was probably getting some care down in Charlotte, too, I just wasn't aware of, because she had about twice as much care and diagnoses as she really did. But most of the predictive tools look pretty good. We're able to actually do some things now where we're able to look at some cost index summaries. You all may be doing some of this within your IPA with your tools already, but this was all new to our organization. We have the ability to get the waste and variation out. So we can break down our diabetics by doctor, by patient, by practice. We can look at who's doing the best job. We can look at who's got the sickest patients. We can, if somebody says my patients really are sick, or they might be, we're able to actually analyze that now and look at ways that we can improve these things together. This is the Humedica tool that allows us to dig into diabetes and 6 of the most chronic diseases like heart failure, where we can actually identify where the opportunity might be. So these are some of our practices, and this is the type of information we didn't have before. But essentially, what you can see is that we have practices with lots of patients. And so the bigger the bubble up here, the more patients that they have. These are our primary care practices. And the further over to the right they are, the sicker the patients are. So as you might imagine, some of the internal medicine practices, which are these 3 right here, have larger practices and sicker patients. And these 2 practices right here are internists. Our family physicians don't have quite the acuity in their practice, but they're seeing a whole lot of folks. And this lady down here is a solo physician, family physician at High Point University, and all she sees are 18-year-olds with STDs, as far as we can tell. And so she has a very different patient population. But this is the type of tools that we have now that we didn't have before. So I'm going to summarize by basically saying that what we're doing requires 3 changes. And it's not rocket science, but it's just a lot of hard work, and it's work that we're going to have to do together. The first is the care model. You actually do have to design the way that you care for patients. And this is the thing that I think our doctors have gotten the most passionate about, because we sort of have said, you're in charge. So we have over 45 physicians in a leadership role in our organization now, whether they're clinical service lines leaders or chief information officer, the chief patient experience officer, whatever that means, which is a guy that really digs patient satisfaction survey results. But everybody's sort of working together to see if we can't do a better job, and we're just sort of inventing it as we go along. The second one really is about infrastructure redesign, facilities, information, and technology, and people. It takes more people to do this stuff. So care navigators and care coordinators and patient care advocates and case managers and psychologists and all these things, it's expensive. So if you don't get the whole risk, you don't get the whole gain share, it's not profitable. You have to have the whole piece. But then when you start seeing the types of results that we've been able to see from the emergency room and from our heart failure and oncology results, you can see where the new value equation might be. And you have to redesign your contract. So my understanding is you all have had a Medicare Advantage product out here that you've been at risk for a long time. So you're actually ahead of us in that regard. That has not been the model in North Carolina. We have, however, now changed all of our practices to the gain share model. So we're in it 100%. So the final thing that the AMGA put out that I thought was particularly good this year was they said these were the elements of a high-performing health system. It was about efficiency and quality, paying doctors differently, everybody differently, accountability, IT care coordination, and organized system of care. You notice what it doesn't say is multi-specialty group or hospital or anything. It just says a high-performing healthcare system. So I don't think anybody needs to be presumptive as to know what that ought to look like. Instead, we ought to think about the functionality and who needs to bring what to the equation that could allow these things to be the case. So I don't know that any of us have the answer. I do know that we've got a really, really big problem in this country, and that if anybody's going to save America, it's going to be the doctors getting their act together and telling our country and telling those that are out there that we got this, we can do this, because we can. There's no reason for us to assume we're a bunch of cats, because we're not. We can do this. And if we don't, we're toast. So thank you very much. I'll be happy to answer some questions. Right.
Exclusively. And so we're looking at, and well, I shouldn't say two. There are a couple of clinics who are doing a good job, but they're larger. And so we're looking at an aging primary care population of physicians. Do you have any insight?
Well, one of the reasons that we formed our multi-specialty group when we did in 93 to 95 was because we had a huge problem with that in our community. This is not a new problem. It kind of got better for a while, but when I came to town in High Point, I was the first primary care physician to come to that town in 10 years. And I joined my mother-in-law and father-in-law, who were aging at the time. They're retired now. And so the specialists in the primary care got together and we created a compensation model where everybody won in that. And that was sort of the way we got started. It's a universal problem. One of the reasons that we have so many mid-levels in our organization is because nurse practitioners and physician assistants is because we have found them to be useful. There's a whole lot more of that in North Carolina than a lot of the other areas of the country because the first two PA schools were at Duke and at Wake Forest, and so we also have several nurse practitioner schools. There is going to be something different in primary care than what's been. I think that what will likely happen is that the payment system's going to change. One of the things that's true with some of the new care models is that we may be paying some of our doctors, $300,000 to be seeing less patients and to organize it around a team of people. That may well it's already starting to attract people back to our organization in primary care that haven't been there in a long period of time. But it's going to be something we're all going to struggle with. There's no perfect solution to it. We are finding that since we've been going through this transformation that we're getting more docs joining us. In fact, I actually have an intern is coming right out of training in the fall of my practice, and it's like a miracle, you know. It's the way it feels, but it's because we're starting to get some attraction with that. Yes, sir.
So have you embraced the hospital concept? I'll preface it by saying when we're talking about Iris,
Yes.
what's going through my mind is how much better off would Iris have been if you had seen her in the emergency room yourself and admitted her and taken care of her, as opposed to turning her over
To the hospitalist. Yep. So our organization started using hospitalists in 1998. The family physicians wanted to get out of the hospital, and so we started it then. Our practice stopped going to the hospital about 2 years ago, mostly my partners. And the trade-off is we're open 7 days a week now. I still miss it. But the truth is it got too hard. You couldn't do what we were doing at the time. You might be able to with some of these new models of care with the extensiveness and whatnot, but it got too hard for most of our folks, and you can't get anybody to do it anymore. For a long period of time, I was actually seeing patients, and the hospitalists would admit my patients, and the next day I was picking them up. But there's certainly something that's been missing as a result of that. I might have put her in pulmonary edema too, but I certainly wouldn't have had her on 20 medicines. Yeah.
Maybe sticking with that theme just a little bit, has there been any shift in the relationship in this community right now? We rarely get phone calls from hospitalists. Patients often come home with medicines from exactly the same classes of medications that they went in with, but now they're all different members of those classes. So now patients go home to their omeprazole that I prescribe, and now they've also got Nexium prescribed, and they went in on Alloprel or lisinopril, and now they're coming out on the other of the two, and they don't know what they're supposed to be doing, and nobody's called me to ask, is there some reason that you don't have on calcium channel blocker? When there is, and they're going out on the calcium channel blocker, and I've seen them 3 days later with severe demented edema that the last time they were on the calcium channel blocker and stuff like that.
So we own our own hospitalist, and to hold them accountable for that, and they have access to our EMR and forth. It's still not enough, and we actually have hired a medical director for them that was actually a real live, honest to goodness internist that did both inpatient and outpatient before he did the hospitalist work, and now have placed a couple of nurse practitioners to make sure that that transition of care is happening more appropriately. It's a problem where we are too. It's a whole lot better with our group though than the competing group that the hospital has. That's really about churning and all that, and the DRGs and making sure that they're doing all this stuff. So we feel better about ours than we do the sort of ones, but they're only in one hospital. It's where most of our specialists practice, but it's not ideal, you're right. The EMR helps it though. Yes?
But do you think we should anticipate that for the docs that are employed by the hospital and the hospital benefiting from facility fees on top of their E&M fees, that facility fee part is going to go away, and are they going to unload these employed physicians?
Well, I hope so. I think facility fees are a crime. Having said that, the hospitals have justified it all these years because they were, quote, not-for-profit and we were, quote, for-profit. And of course, the answer was we didn't have any way of having that much margin on the patients that were uninsured. With the Affordable Care Act now, with a lot of people having some access to insurance, at least in this state, that will take that argument away from the hospitals, which is one reason they took out their disproportionate share. Out of it's the same thing. What my understanding is happening in Washington right now is very interesting in the SGR argument that there's a bipartisan group that's looking at how they're going to, quote, fix it. And it's very interesting. I've spoken in the past 3 weeks to the advisory board the American Medical Association and the American Medical Group Association's leadership about this. They're getting ready to differentiate the payment rates between those that go into an ACO versus those that don't among physicians. And they're also looking at getting rid of the facility fee for hospitals to sort of pay for a lot of the stuff. Partly that would pay for the SGR. Now the hospitals, you know, are going to fight that tooth and nail. And so what they'll have to come back on is something related to their not-for-profit status and charity and all that. So it may be the red states that are not doing the Medicaid expansion. It's going to be interesting to see how that plays out, because it's been what they've used forever. But personally, I think it's terrible.